Foundations of Maternal-Newborn and Women's Health Nursing by Murray, McKinney, Holub, and Jones. 7th edition. Chapter 7. Antepartum Assessment, Care, and Education. Antepartum Assessment and Care. The objective of antepartum care is to promote optimum health of the mother and infant. Prenatal care involves early and continuing risk assessments, health education, counseling, and social support. Ideally, antepartum care begins before conception and continues on a regular basis until birth. Although no prospective controlled trials have demonstrated the efficacy of prenatal care overall, inadequate antepartum care is associated with low birth weight and an increased incidence of prematurity. Prenatal visits provide clinicians with the opportunity to address primary health care concerns as well as assessing pregnancy risks and potential or existing complications. In 2015, birth certificate data show 77% of women giving birth received early prenatal care in the first trimester, while 6% of women began prenatal care in the third trimester or did not receive any prenatal care. The Healthy People 2020 goal is for at least 77.6% of women to begin antepartum care in the first trimester. Preconception and interconception care. Ideally, the first visit takes place before conception. Preconception care, the period of time prior to conception, and interconception care, the period of time between pregnancies, are important to identify problems or risk factors that might harm the mother or the infant once pregnancy occurs, and to provide education to help promote a healthy pregnancy. The early weeks of pregnancy are particularly important because the fetal organs are forming and are especially sensitive to harm. Many women do not begin prenatal care until after this sensitive period, and injury may already have transpired. Interconception care is especially important for women who have had previous pregnancy or birth complications. It also identifies and treats risk factors that have occurred since the last pregnancy. Because many pregnancies are unintended, any visit to a healthcare provider by a woman of childbearing age should be seen as an opportunity for preconception or interconception care. This care can be part of developing a reproductive life plan that includes deciding the desired number and spacing of pregnancies. Such a plan helps women make changes to improve birth outcomes. Chronic conditions such as asthma, obesity, diabetes, or hypothyroidism should be addressed before pregnancy occurs. Previous reproductive problems and family history of possible genetic conditions are explored. Genetic testing may be indicated by the family history. See Chapter 4. During a preconception visit, the healthcare provider obtains a complete history and performs a physical examination. The woman is assessed for health problems, e.g., diabetes, hypertension, sexually transmitted diseases, or psychological problems, harmful habits, such as the use of alcohol or drugs, or social problems, such as intimate partner violence, that might adversely affect pregnancy. If problems are discovered, intervention may be started immediately to avoid complications or worsening of the woman's condition or situation because of pregnancy. Screening for rubella, varicella, and hepatitis B is performed, and the vaccines are given, if indicated. The woman should be instructed to wait at least 1 month after receiving rubella and varicella vaccines before conceiving to minimize risk to the fetus. If the woman is taking prescription and over-the-counter OTC drugs, vitamins, or other supplements, their effect on pregnancy is evaluated and changes made, if necessary. Approximately 50% of women report taking at least one medication during pregnancy. Potentially teratogenic medications should be evaluated and changed to less harmful drugs, if possible, for attempting pregnancy. Use of complementary or alternative therapies is addressed because some may be safe at other times, but harmful during pregnancy. Avoidance of common teratogens or other harmful substances is discussed. Women who are obese can obtain help to lose weight before conceiving. Referral to smoking cessation programs may be indicated. The woman is advised to consume 400 to 800 micrograms of folic acid daily for at least 1 month before conception and 2 to 3 months after conception to decrease the risk for neural tube defects. A daily intake of 600 micrograms is recommended for the rest of the pregnancy. Women who have previously given birth to an infant with a neural tube defect should consult with their provider about increasing the dosage to 4,000 micrograms of folic acid daily during the 4 weeks before pregnancy and throughout the first trimester. Women on anti-epileptic medications are advised to take 1,000 micrograms of folic acid during this time frame as well. Initial prenatal visit. If a preconception visit has occurred recently, many initial prenatal assessments will have been completed. If not, the nurse practitioner, nurse midwife, or physician will complete a thorough history and physical examination. The obstetric nurse may play an essential role in this intake visit as well, verifying history, uncovering potential risk factors, and providing early pregnancy education. The following are the primary objectives of the first antepartum visit. Establish trust and rapport with the childbearing family. Verify or rule out pregnancy. Evaluate the pregnant woman's physical and psychological health relevant to childbearing. Assess the growth and health of the fetus. Establish baseline data for comparison with future observations. Evaluate the psychosocial needs of the woman and her family. Assess the need for counseling or teaching. Negotiate a plan of care to promote optimal health of the mother and baby. History. Obstetric history. The obstetric history provides essential information about previous pregnancies and may alert the healthcare provider to possible problems in the present pregnancy. Components of this history include the following: gravida, para, abortions, spontaneous or elective termination of pregnancies before the 20th week of gestation. Spontaneous abortion is frequently called miscarriage, and living children. Length of previous gestations, weight of infants at birth, labor experiences, type of deliveries, locations of births, and names of providers. Types of anesthesia and any difficulties with anesthesia during childbirth of previous surgeries. Maternal complications such as hypertension, diabetes, infection, bleeding, or psychologic complications. Infant complications. Methods of infant feeding used in the past and currently planned. Special concerns. Gravida refers to a woman who is or has been pregnant, regardless of the length of the pregnancy. A prima gravida is a woman pregnant for the first time. A multigravida has been pregnant more than once. Para refers to the number of pregnancies that have ended at 20 or more weeks, regardless of whether the infant was born alive or stillborn. A multiple gestation pregnancy, such as twins or triplets, is still one pregnancy and therefore one para. A nullipara is a woman who has never been pregnant or has not completed a pregnancy of 20 weeks or more. A primipara has delivered one pregnancy of at least 20 weeks. A multipara has delivered 2 or more pregnancies of at least 20 weeks. There are 2 methods of summarizing a woman's obstetric history, gravida and para. The first uses 2 digits, gravida, the number of times she has been pregnant, and para, the number of completed pregnancies of 20 weeks or more. The second method, described by the acronym GTPAL, is more informative because it uses 5 digits. G equals pregnancies or gravida, T equals term pregnancies delivered, P equals preterm pregnancies delivered, A equals abortions, spontaneous and induced, and L equals living children. Box 7.1. Nurses should use caution when discussing gravida and para with the expectant mother in the presence of her family or significant other. Although the antepartum record may indicate a previous pregnancy or childbirth, she may not have shared this information with her family, and her right to privacy could be jeopardized by probing questions in their presence. The pregnancy may have terminated in elective or spontaneous abortion or in the birth of an infant who was placed for adoption. The confidentiality of the pregnant woman should always be protected. The nurse should wait until the woman is alone if it is necessary to clarify information about her gravida or para. Menstrual history and estimated date of delivery. A complete menstrual history is necessary to establish the estimated date of delivery, EDD, and therefore the gestational age of the fetus and any given time. The EDD is important in deciding when to schedule certain tests or procedures commonly performed during pregnancy. Common practice is to estimate the EDD on the basis of the first day of the last normal menstrual period, LNMP. Although ovulation and conception occur approximately 2 weeks after the beginning of menstruation in a regular 28-day cycle, the average duration of pregnancy from the first day of the LNMP is 40 weeks or 280 days. The Nagel's rule is often used to establish the EDD. The method involves subtracting 3 months from the date the LNMP began, adding 7 days, and then correcting the year, if appropriate. For example, LNMP, August 30th, 2018. Subtract 3 months, May 30th, 2018. Add 7 days and change the year, June 6th, 2019. Calculations of EDD may be inaccurate in some situations. For example, the Nagel's rule is less accurate when the woman's menstrual cycle is very irregular. To determine EDD quickly, many healthcare providers also use a gestational wheel or an EDD calculator tool application designed for electronic medical records or smartphones. Ultrasound measurements taken early in pregnancy, before 20 weeks of gestation, can more accurately determine the gestational age. Gynecologic and contraceptive history. Any previous gynecologic problems should be identified. STDs should be treated. Infertility problems with past or the current pregnancy should be discussed. A detailed history of contraceptive methods is important. Studies have shown no increased risk for congenital malformations when women conceive while using hormonal contraceptives. Any woman who becomes pregnant should stop taking hormonal contraceptives and consult with a healthcare provider. Pregnancy with an intrauterine device, IUD, in place is unusual, but it can cause complications such as spontaneous abortion, infection, and preterm delivery. The patient should be evaluated for ectopic pregnancy. As soon as the pregnancy is confirmed, the IUD should be removed promptly by a provider. A woman who shows signs of infection with an IUD in place should receive intensive antibiotic treatment and have her uterus evacuated. Medical and surgical history. Chronic conditions can affect the outcome of the pregnancy and should be investigated. Infections, surgical procedures, and trauma may complicate the pregnancy or childbirth and should be documented. The history includes the following: age, race, and ethnic background, risk for specific genetic problems such as sickle cell disease, thalassemia, cystic fibrosis, and Tay-Sachs disease, childhood diseases and immunizations, chronic illnesses, onset and treatment, such as asthma, heart disease, hypertension, diabetes, renal disease, and lupus, previous illnesses, surgical procedures, and injuries, particularly of the pelvis and back, previous infections, such as hepatitis, STDs, tuberculosis, and presence of group B streptococcus, history of and treatment for anemia, including any previous blood transfusions, bladder and bowel function, problems or changes, amount of caffeine and alcohol consumed each day, tobacco use in any form, number of years and daily amount, prescription, OTC, and illicit drugs, name, dose, frequency, complementary or alternative therapies used, appetite, general nutrition, history of eating disorders, contact with pets, particularly cats, increased risk for infections such as toxoplasmosis, allergies and drug sensitivities, occupation, and related risk factors. Family history. A family history provides valuable information about the general health of the family, including chronic diseases such as diabetes and heart disease, and infections such as tuberculosis and hepatitis. In addition, it may reveal information about patterns of genetic or congenital anomalies. Partner's health history. The partner's history may include significant health problems, such as genetic abnormalities, chronic diseases, and infections. Use of drugs such as cocaine and alcohol may affect the family's ability to cope with pregnancy and childbirth. Tobacco use by the partner increases the risk for upper respiratory tract infections for both the mother and the infant from exposure to passive smoke. In addition, the father's blood type and Rh factor are important if the mother is Rh negative or type O, because blood incompatibility between the mother and fetus is possible. Psychosocial history. The psychosocial history, including mental health, substance abuse, risk for violence or abuse, and coping abilities, should be elicited during the initial visit. Physical examination. Many women have not had a recent physical examination before becoming pregnant. Therefore, a thorough evaluation of all body systems is necessary to detect previously undiagnosed physical problems that may affect the pregnancy outcome. It also establishes baseline levels to guide the treatment of the expectant mother and fetus throughout pregnancy. Vital signs, blood pressure. Position, anxiety, pain, and the use of alcohol or tobacco products can affect blood pressure. BP should be obtained using an appropriate size cuff with the woman seated and her arms supported in a horizontal position at heart level. The same arm should be used for each assessment. There may be differences between BP values obtained manually and BP values obtained with automatic cuffs. Documentation should include the position, arm used, pressures obtained, and type of sphygmomanometer used. The nurse may notice a normal decrease in BP during first and second trimesters, which normalizes by the third trimester. See Chapter 6. A BP of 140/90 or higher may indicate chronic hypertension or preeclampsia and requires additional evaluation. Chapter 10. Pulse. The normal adult pulse rate is 60 to 90 beats per minute. Tachycardia is associated with anxiety, hyperthyroidism, and infection and should be investigated. Apical pulse should be assessed for at least 1 minute to determine the amplitude and regularity of the heartbeat and presence of murmurs. Pedal pulses are assessed to determine the presence of circulatory problems in the legs. Pedal pulses should be strong, equal, and regular. Respirations. Respiratory rate during pregnancy is in the range of 16 to 24 breaths per minute. Tachypnea may indicate respiratory tract infection or cardiac disease. Breath sound should be equal bilaterally. Chest expansion should be symmetric, and lung field should be free of abnormal breath sounds. Temperature. Normal temperature during pregnancy is 36.6 Celsius to 37.6 Celsius. That's 97.8 degrees Fahrenheit to 99.6 degrees Fahrenheit. Fever suggests infection and may require medical management. Cardiovascular system. Additional assessment of the cardiovascular system includes observation for venous congestion, which can develop into varicosities and edema. Venous congestion is most commonly noted in the legs, the vulva as varicosities, or the rectum as hemorrhoids. Edema of the legs may be a benign condition that reflects pooling of blood in the extremities caused by occlusion of the pelvic veins and inferior vena cava by the large uterus. This results in a shift of intravascular fluid into interstitial spaces. When pressure exerted by a finger leaves a persistent depression, pitting edema is present. See Figure 17.6. Musculoskeletal system. Body mechanics and changes in posture and gait should be addressed. Poor body mechanics during pregnancy may place strain on the muscles of the lower back and legs. Many joints have increased mobility during pregnancy, which contributes to posture changes, potentially leading to lower back pain. Height and weight. An initial weight is recorded to establish a baseline for evaluation of weight gain throughout pregnancy. The body mass index should be calculated. Women who are underweight before pregnancy are at risk for having low birth weight infants. Obesity is a special concern during pregnancy. Chapter 10. Obesity increases the incidence of hypertensive disorders, gestational diabetes, postpartum hemorrhage, poor labor progression, cesarean delivery, anesthesia complications, wound infection, and birth of large for gestational age infants. Obese women often need closer observation and careful management of complications during pregnancy. Tests of fetal well-being may be important during the third trimester. Abdomen. The contour, size, and muscle tone of the abdomen should be assessed. The fundal height should be measured if the fundus is palpable above the symphysis pubis, Figure 7.1. The fetal heart rate should be auscultated, counted, and recorded if the pregnancy is advanced enough, 10 to 12 weeks by Doppler, 18 to 20 weeks by fetoscope. Neurologic system. A complete neurologic assessment is not necessary for women who have a negative history and are free from signs or symptoms indicating a problem. However, deep tendon reflexes should be evaluated because hyperflexia is associated with complications of pregnancy. Chapter 10. Carpal tunnel syndrome. Carpal tunnel syndrome is believed to result when edema compresses the median nerve at the point where it passes through the carpal tunnel of the wrist. Symptoms include pain, burning, numbness, or tingling of the hand and wrist. Splinting of the wrist at night may provide improvement. It resolves by 3 months after childbirth for most women. Integumentary system. Skin color should be consistent with racial background. Pallor may result from anemia, and jaundice may indicate hepatic disease. Lesions, bruising, rashes, areas of hyperpigmentation related to pregnancy, melasma, linea nigra, and stretch marks, striae, should be noted. Nail beds should be pink with instant capillary return. Endocrine system. The thyroid enlarges moderately during the second trimester. However, gross enlargement, nodules, or tenderness may indicate thyroid disease and require further medical evaluation. Gastrointestinal system. Mouth. Mucous membrane should be pink, smooth, glistening, and uniform. Lips should be free of ulcerations. Gums may be red, tender, and edematous and may bleed more easily. Teeth should be in good repair. dental plaque may increase, and a temporary increase in tooth mobility may occur. The woman should be referred for regular dental care. The second trimester may be the most comfortable time for dental care. However, if necessary, dental care can be performed during the third trimester if the woman is positioned to avoid supine hypotensive syndrome. Intestine. A warm stethoscope for assessing bowel sounds is most comfortable for the pregnant woman. Bowel sounds may be diminished because of the effects of progesterone on smooth muscle. Bowel sounds are often increased if a meal is overdue or diarrhea is present. Problems with constipation can be discussed during abdominal examination. Urinary system. A clean catch midstream urine sample is tested for UTI and indicators of other complications. Although a trace amount of protein may be present in the urine, the amount should not increase. Its presence may indicate kidney disease, preeclampsia, or contamination by vaginal secretions. Small amounts of glucose may indicate physiologic spilling that occurs during normal pregnancy. Ketones may be found in the urine after heavy exercise or as a result of inadequate intake of food and fluid. Increased bacteria in urine is associated with UTI, which is common during pregnancy. A baseline urinalysis or culture may detect any underlying bacterial infections that warrant treatment to prevent more serious UTIs, such as pyelonephritis. Reproductive system. Breasts. Breast size and symmetry, condition of the nipples, erect, flat, or inverted, and presence of colostrum should be noted. Any lumps, dimpling of the skin, or asymmetry of the nipples requires further evaluation. Breast tissue changes during pregnancy frequently cause increased tenderness and sensitivity during breast examination. External reproductive organs. The skin and mucous membranes of the perineum, vulva, and anus are inspected for excoriations, growths, ulcerations, lesions, varicosities, warts, cankers, and perineal scars. Enlargement, tenderness, redness, or discharge from the Bartholin or Skene gland may indicate gonorrheal or chlamydial infection. The examiner should obtain a specimen for culture from any discharge from lesions or inflamed glands to determine the causative organisms and to provide effective care. Internal reproductive organs. A speculum inserted into the vagina permits the examiner to see the walls of the vagina and the cervix. The cervix should be pink in a non-pregnant woman and bluish-purple in a pregnant woman, Chadwick's sign. The external cervical os is closed in prima gravidis, but one fingertip may be admitted into multiparas. The cervix feels relatively firm except during pregnancy, when marked softening is noted, Goodell's sign. Routine cervical cultures for gonorrhea and chlamydial infections are generally obtained during the initial pregnancy examination. The examiner also collects a specimen for a Papa-Nicolau or PAP test to screen for cervical cancer if indicated. A bimanual examination involves the use of both hands, one on the abdomen and the other in the vagina, to palpate the internal genitalia. The examiner palpates the uterus for size, contour, tenderness, and position. The uterus should be movable between the two examining hands and should feel smooth and enlarged according to gestational age. The ovaries, if palpable, should be about the size and shape of almonds and non-tender. Pelvic measurements. Pelvic measurements may be assessed at this time to determine whether the shape and size of the bony pelvis are adequate for a normal vaginal birth. See Figure 12.4. Laboratory data. Table 7.1 lists laboratory tests commonly performed during pregnancy and describes the purpose and significance of each test. Table 7.2 shows laboratory values for pregnant and non-pregnant women. Risk assessment. Risk assessment begins at the initial visit when the healthcare provider identifies factors that put the expectant mother or fetus at risk for complications and determines the need for specialized care. Women with identified risk factors may require closer surveillance to monitor maternal and fetal well-being. Furthermore, risk factors change as pregnancy progresses, and risk assessment should be updated throughout pregnancy. Table 7.3 lists major risk factors and their implications. Subsequent visits. Ongoing antepartum care is important to the successful outcome of pregnancy. Although the recommended number of visits can be reduced for women without complications, the usual schedule for prenatal assessment in normal pregnancy is as follows. Conception to 28 weeks, every 4 weeks. 29 to 36 weeks, every 2 weeks. 37 weeks to birth, weekly. Although the preceding schedule is the traditional model of prenatal care, other options do exist. Centering pregnancy is an example of an evidence-based alternative method of care. The method involves 10 sessions of 1.5 to 2 hours with groups of 8 to 12 women meeting with a facilitator who may be a nurse and a healthcare provider, beginning at 12 to 16 weeks of pregnancy and ending soon after childbirth. Women assess their own BP and weight during the first 30 minutes of the session, promoting personal ownership and responsibility. Each visit includes an individual assessment with time alone with a healthcare provider, typically a nurse midwife or nurse practitioner. They then participate in a group educational discussion with peers who are of similar gestational ages. The social support provided by the group is an important benefit. Women participating in this form of care have been satisfied with their care, reported a greater positive influence on stress, and had favorable pregnancy outcomes. More information is available at www.centeringhealthcare.org. Vital signs. Significant deviations from baseline values for vital signs indicate the need for further assessment. BP should be measured in the same arm, with the mother in the same position each time. Weight. Weight should be recorded and evaluated for expected progress. Inadequate weight gain may indicate the pregnancy is not as advanced as was thought or the fetus is not growing as expected. A sudden rapid weight gain may indicate excessive fluid retention. Urine. Urine may be tested at each visit for protein, glucose, and ketones. Urine is also checked for nitrates to identify UTI and the need for a urine culture. Fundal height. Measuring fundal height is an inexpensive and non-invasive method of evaluating fetal growth and confirming gestational age. It is performed at each visit once the fundus is high enough to be palpated in the abdomen. The bladder should be empty to avoid elevation of the uterus. The woman lies on her back with her knees slightly flexed. The top of the fundus is palpated, and a tape measure is stretched from the top of the symphysis pubis over the abdominal curve to the top of the fundus. From 20 weeks until 32 weeks of gestation, the fundal height, measured in centimeters, is approximately equal to the gestational age of the fetus in weeks. If a discrepancy between fundal height and weeks of gestation is present, additional assessment is necessary. The EDD may be incorrect and the pregnancy more or less advanced than thought. The number of fetuses present, fetal growth, the amount of amniotic fluid, presence of leiomyomata fibroids, or gestational trophoblastic disease, hydatidiform mole, will affect the fundal height. Ultrasonography may be performed to obtain further information. Leopold maneuvers. Leopold maneuvers provide a systematic method for palpating the fetus through the abdominal wall during the latter part of pregnancy. These maneuvers provide valuable information about the location and presentation of the fetus. See Procedure 15.1. Fetal heart rate. The fetal heart rate should be between 110 and 160 BPM. The location of the fetal heart sounds helps determine the position in which the fetus is entering the pelvis. For example, fetal heart sounds heard in an upper quadrant of the abdomen suggest the fetus is in breech presentation. Fetal activity. Fetal movements, quickening, are usually first noticed by the expectant mother at 16 to 20 weeks of gestation and gradually increase in frequency and strength. In the last trimester, the woman may be asked to count fetal movements, commonly called kick counts. In general, fetal activity is a reassuring sign of a physically healthy fetus. Obese women may have decreased perception of fetal movements. Signs of labor. The woman should be asked about signs of labor at each visit. A discussion of contractions, bleeding, and rupture of membranes will help the woman learn to identify preterm labor. She should be cautioned to call the healthcare provider or go to the hospital if she thinks she might be in labor. During the third trimester, a discussion of the normal course of labor is important to prepare the woman. Ultrasonographic screening. Ultrasonography is a commonly used prenatal diagnostic procedure, Chapter 9. During early pregnancy, ultrasonography helps determine gestational age, fetal number, and cardiac activity. Ultrasound during the second and third trimesters can be useful when there is a discrepancy between the woman's last menstrual period and uterine size to detect fetal anatomic defects, to observe for abnormal fetal growth, to check placental location and amniotic fluid volume estimates, and to determine fetal gender. Ultrasound also may be used to measure cervical length in women at risk for preterm delivery. Glucose screening. Initial screening for diabetes in pregnant women may be by medical history, clinical risk factors, and/or laboratory tests. For women with significant history or risk factors, the blood glucose level is assessed at 24 to 28 weeks of gestation with a 1-hour oral glucose challenge test. If the result is 140 milligrams per deciliter, mg per dl, or higher, the woman receives 3-hour oral glucose tolerance test to determine whether she has gestational diabetes. In high-risk women or high-risk populations, laboratory screening at the initial visit is also indicated and includes a fasting glucose test and a hemoglobin A1C. Isoimmunization. Antibody tests may be repeated in the third trimester in women who are Rh negative if the father of the baby is Rh positive. If unsensitized, the woman should receive RHO-D immune globulin, RhoGAM, prophylactically at 28 weeks of gestation after any invasive procedure such as amniocentesis or abdominal trauma, and again within 3 days after birth. The woman should be counseled to notify her provider of any episodes of vaginal bleeding or abdominal trauma during the pregnancy. Pelvic examination. During the last month of pregnancy, the obstetric provider may perform a pelvic examination to determine cervical changes. The descent of the fetus and the presenting part are also assessed at this time. Psychosocial assessments. The woman's psychosocial adaptation should be assessed at each visit, Table 7.4. The nurse should ask the patient about mood swings, body image, dreams, and concerns. In addition to assessment for normal psychosocial changes in pregnancy, ACOG recommends all women be screened at least once during the perinatal period for depression and anxiety. Multifetal pregnancy. A multifetal pregnancy is a pregnancy in which 2 or more embryos or fetuses are present simultaneously. Diagnosis. Multifetal pregnancies are more likely in women who are over 35 years of age or in those who have a personal or family history of multifetal pregnancies. Advances in reproductive technology has contributed to an increased incidence of multifetal gestation. Women with multifetal pregnancies are larger than expected for the weeks of gestation, report increased fetal movements, and gain more weight. The funnel height is often 4 centimeters larger than expected on the basis of gestational age computed for the last menstrual period. When more than one fetus is suspected, diagnosis should be confirmed with ultrasonography. Separate fetuses and heart activities may be seen as early as 6 weeks of gestation. Maternal adaptation to multifetal pregnancy. The degree of maternal physiologic changes is greater with multiple fetuses than with a single fetus. For example, with twins, blood volume increases 500 milliliters more than the amount needed for a single fetus. This increases the workload of the heart and may contribute to fatigue and activity intolerance. The additional size of the uterus intensifies the mechanical effect of pregnancy. The uterus may achieve a volume of 10 liters or more and weigh more than 9 kilograms, 20 pounds. Respiratory difficulty increases because the over-distended uterus causes greater elevation of the diaphragm. The uterus may also cause more compression of the large vessels, resulting in more pronounced and earlier supine hypotension. Greater compression of the ureters can occur, and maternal edema and slight proteinuria are common. Compression of the bowel makes constipation and hemorrhoids persistent problems. Nausea and vomiting occur 3 times as often as in single fetus pregnancies because of the increased hormones. Fatigue and backache are also increased. Antepartum care in multifetal pregnancy. Early diagnosis of multifetal pregnancy allows time for the family to be educated about the many ways in which the pregnancy will differ from those involving a single fetus. Special antepartum classes can explain the need for increased nutrition, rest, and fetal monitoring. Instruction about signs of preterm labor, a common complication, should begin early. Discussions of the possible need to reduce activity and take frequent rest periods, as well as the potential family stress caused by a high-risk pregnancy, should be included. Women with multifetal pregnancies have more frequent antepartum visits to allow early detection of common complications. These include preeclampsia, preterm labor, placental abruption, congenital anomalies, low birth weight, and postpartum hemorrhage. Ultrasound scanning may be performed every 4 to 6 weeks beginning at 24 weeks of gestation to assess the growth of each fetus. Assessment of cervical lengths using ultrasound may help determine increased risk for preterm delivery. Nutritional education is essential. Adequate calories, iron, calcium, folic acid, and vitamins are important. Women with a normal pregnancy weight are advised to gain 37 to 54 pounds during a twin pregnancy. The woman may have concerns and may need more support than women with only one fetus. Discomforts of pregnancy, which are merely annoying to other women, are increased during multifetal pregnancies. Because preterm birth is the most frequent complication in multifetal pregnancies, teaching about signs of labor and how to respond should begin early in pregnancy. In addition, the financial burden of medical and hospital care during and after pregnancy is increased. Concerns about the effect of more than one newborn on the family should be discussed. The woman may need referral for assistance in these areas. Common discomforts of pregnancy. Many women experience discomforts of pregnancy that are not serious but detract from the feeling of comfort and well-being. Nausea and vomiting. The nausea and vomiting in pregnancy are frequently called morning sickness because these symptoms are more acute on arising. However, it may occur at any time and may continue throughout the day. Symptoms may be aggravated by odors, such as from cooking, fatigue, and emotional stress. Women need reassurance that although morning sickness is distressing, it is common, temporary, and will not harm the fetus. Morning sickness should be distinguished from hyperemesis gravidarum, severe vomiting accompanied by weight loss, dehydration, electrolyte imbalance, and ketosis. See Chapter 10. Nausea and vomiting that significantly interfere with the woman's intake of nutrients may decrease the nutrients available to the fetus. Eating small, frequent meals and high-protein snacks may help alleviate symptoms. Vitamin B6, pyridoxine, doxylamine, and phenothiazines may be prescribed by the healthcare provider if necessary. Many non-pharmacologic alternative therapies may be helpful, including ginger, peppermint tea, and acupressure. Although these therapies may be helpful in some women, the efficacy of many of these alternative remedies is not significant. The healthcare provider should be consulted before complementary and alternative methods are used. Heartburn. Heartburn, an acute burning sensation of the epigastric and sternal regions, occurs in up to 80% of pregnant women. It is caused by reverse peristaltic waves that produce regurgitation of stomach contents into the esophagus. The underlying causes are diminished gastric motility, displacement of the stomach by the enlarging uterus, relaxation of the lower esophageal and gastric sphincters, and increased intra-abdominal and intragastric pressure as pregnancy progresses. If common remedies and dietary changes are not effective, the provider may prescribe histamine 2 receptor inhibitors. Backache. Backache occurs in 45 to 59% of pregnant women. Increased joint mobility, lumbar lordosis, and relaxed ligaments contribute to the problem. Teaching correct posture and body mechanics can help prevent back pain. Stooping or bending puts a great deal of strain on the muscles of the lower back. Instruction should include correct and incorrect methods of lifting, figure 7.3, and exercises to relax the shoulders and help prevent backache, figure 7.4. Round ligament pain. Round ligament pain is a sharp pain in the inguinal area or on the side, usually on the right. It results from softening and stretching of the ligament from hormones and uterine growth. In some instances, it may be difficult for the woman to distinguish from uterine contractions. Careful assessment to rule out contractions followed by reassurance are appropriate measures. Urinary frequency. Although urinary frequency is a common complaint during pregnancy, the condition is temporary and is managed by most women without undue stress. Urinary incontinence, especially in the third trimester, may occur. Kegel exercises may be helpful in maintaining bladder control. Varicosities. Varicosities occur in 40% of pregnancies. They are seen more often in women who are obese, are multiparas, or have a family history of varicose veins. During pregnancy, the weight of the uterus partially compresses the veins returning blood from the legs, and estrogen causes elastic tissue to become more fragile. As blood pools, the vessels dilate and become engorged, inflamed, and painful. Varicose veins are exacerbated by prolonged standing, during which the force of gravity makes blood return more difficult. Varicosities are usually confined to the legs, but may involve the veins of the vulva or rectum, hemorrhoids. Varicosities may range from barely noticeable blemishes with minimal discomfort at the end of the day to large, tortuous veins that produce severe discomfort with any activity. They usually improve after childbirth, but do not go away completely. Hemorrhoids. Hemorrhoids are varicosities of the rectum and may be external, outside the anus, or internal, above the sphincter. Some common causes are vascular engorgement of the pelvis, constipation, straining at stool, and prolonged sitting or standing. Pushing during the second stage of labor aggravates the problem, which may continue into the postpartum period. Hemorrhoids often shrink and become less troublesome postpartum. Constipation. Occasional constipation is not harmful, although it can cause feelings of abdominal fullness and flatulence and aggravate painful hemorrhoids. Intestinal motility is reduced during pregnancy as a result of progesterone, pressure from the enlarged uterus, and decreased activity. The result may be hard, dry stools and decreased frequency of bowel movements. Iron supplementation often increases constipation. Increasing fluid and fiber intake may help to decrease the condition. Leg cramps. Painful contractions of the muscles of the legs occur in 25 to 50% of pregnant women. Cramps often occur during sleep when the muscles are relaxed or when the woman stretches and extends her feet with the toes pointed. Magnesium and vitamin D supplementation may be used. Venous congestion in the legs during the third trimester also contributes to leg cramps. Dorsiflexion of the foot may relieve the cramp. Application of the nursing process. Family responses to physical changes of pregnancy. The nursing process focuses on identifying each family's unique responses to the physiologic changes of pregnancy, determining factors that might interfere with their ability to adapt to changes, and finding solutions to identify problems. Assessment. Assess the woman's response to physiologic processes of pregnancy and explore the family's preparation for the birth. Use structured interviews and planned teaching sessions, as well as more informal, spontaneous discussions during assessments. Review the history and physical examination to obtain important data. Gather information from the expectant mother as well as from her partner and significant family members if appropriate. Identification of patient problems. When analyzing data, nurses should use all their critical thinking skills before reaching a conclusion about the most significant patient problems or opportunities. Much of the time, the nurse will work with the family to enhance their opportunity for health improvement during the antepartum period. Most families express an intense desire to protect the health of the unborn child and the well-being of the mother. Planning. Expected outcomes. If the expected outcomes have been achieved, the woman will explain self-care practices that promote safety and well-being for herself and the fetus. Describe relief measures for common discomforts of pregnancy. Identify personal habits or behaviors that could adversely affect her health or the health of the fetus and develop a plan to modify these behaviors. Interventions. Teaching health behaviors. Teaching should be addressed at each visit and should focus on the mother's immediate questions and concerns. Common concerns are discussed here. Bathing. Bathing protects pregnant women from infections and promotes comfort by dissipating heat produced by the increased metabolism. During the last trimester, when her balance is altered by a changing center of gravity, the woman is prone to falls. Advise her to use non-skid pads in the tub or shower. Tubs and saunas. Although warm baths and showers help relax tense and tired muscles, pregnant women should avoid activities that may cause hyperthermia. Maternal hyperthermia, particularly during the first trimester, may be associated with fetal anomalies. Caution the woman not to be in a sauna for more than 15 minutes or a hot tub for more than 10 minutes and to keep her head, chest, shoulders, and arms out of the water. Douching. Some women douche because they believe it increases cleanliness and prevents infection. However, despite increased vaginal discharge during pregnancy, douching is unnecessary at any time. Douching increases the risk for ectopic pregnancy, cervical cancer, STDs, pelvic inflammatory disease, and endometritis. Bacterial vaginosis occurs more often in women who douche. In pregnancy, bacterial vaginosis has been associated with spontaneous abortion, preterm birth, premature rupture of membranes, and chorioamnionitis. Discuss women's reasoning for douching and explaining it is unnecessary. Breast care. Instruct the expectant mother to avoid using soap on her nipples because it removes the natural lubricant secreted by Montgomery glands in the areola. Advise her to wear a well-fitting supported bra to help prevent loss of tone as the breasts become heavier during pregnancy. Wide bra straps distribute the weight evenly across the shoulders and provide greater comfort. Inform the couple that breast stimulation increases oxytocin secretion and may cause uterine contractions. Therefore, it is unsafe if the woman has a history of preterm labor or existing signs of preterm labor such as rhythmic pelvic pressure or regular uterine contractions. No breast or nipple preparation is necessary during pregnancy for breastfeeding. Nurses and providers should promote and discuss the benefits of breastfeeding early in pregnancy and throughout prenatal care. Clothing. Recommend practical, comfortable, and non-constricting clothing. Tight jeans or pantyhose, which may impede venous circulation, should be avoided or worn only for short periods. Suggest the woman wear low heels because they do not interfere with balance. High heels increase the curvature of the lower spine, lordosis, increasing backache and making her more likely to fall. Exercise. Exercise during pregnancy is generally beneficial and can strengthen muscles, reduce backache and stress, and provide a feeling of well-being. The amount and type of exercise recommended depend on the physical condition of the woman and the stage of pregnancy. Exercise tolerance is often decreased, but mild to moderate exercise is generally not a problem. Teach women who have no medical or obstetric complications to exercise in moderation for at least 20 to 30 minutes or more on most, if not all, days of the week. Recreational sports can be continued if no risk for falling or abdominal trauma is present. Joint and ligament laxity and lumbar lordosis increase the risk for injury, especially in the third trimester. Contact sports and exercise with a high risk for falling, such as rock climbing or skiing, should be avoided. Exercise in the supine position should be discontinued after the first trimester to avoid supine hypotensive syndrome. Walking is an ideal exercise because it stimulates muscular activity, gently increases respiratory and cardiovascular effort, and does not result in fatigue or strain. Swimming and water exercises are excellent during pregnancy because the buoyancy of the water helps prevent injuries. Riding a stationary bike and yoga are also helpful. Exercise classes, especially for pregnant women, are often available and offer companionship with other women having similar experiences. Instruct the woman not to begin strenuous exercise programs or intensify training during pregnancy. Those who have been exercising strenuously before pregnancy should consult the healthcare provider, but may be able to continue some of their usual routine. As pregnancy progresses, the exercise program may need modification because the change in the woman's center of gravity makes her more prone to falls. Therefore, an activity may be safe in the first trimester, but not in the third. Pregnant women should avoid becoming overheated during exercise because heat is transmitted to the fetus, causing an increase in fetal oxygen needs. Women should allow a cool-down period of mild activity after exercising. To prevent dehydration, it is important to take liquids frequently while exercising. Exercise should be tailored to the way the woman feels to avoid becoming overly fatigued. Generally, if a woman cannot carry on a conversation while exercising, she is doing too much. The woman should stop exercising and seek medical advice if she has chest pain, dizziness, headache, vaginal bleeding, decreased fetal movement, or signs of labor while exercising. Sleep and rest. Problem sleeping may begin as early as the first trimester and continue throughout pregnancy. Finding a comfortable position for rest may be difficult by the third trimester. Backache, abdominal discomfort and contractions, leg cramps, fetal movement, and urinary frequency may interfere with sleep. Suggest the woman use pillows to support the abdomen and back to enhance sleep. Figure 7.5. Emphasize that frequent rest periods are beneficial, even if the woman does not fall asleep. Suggest relaxation exercises to use during the day and before bed. In addition, avoiding caffeine and limiting fluids at night may be helpful. Sexual activity. Sexual intercourse is generally safe for the healthy pregnant woman. Nutrition. A discussion of nutrition should be part of each visit. The nurse should assess the woman's diet and use of prenatal vitamins and answer any questions she may have. See Chapter 8. Employment. Most women of childbearing age in the United States are employed outside the home, and most continue to work during pregnancy. Women with uncomplicated pregnancies can usually continue working until they begin labor, if they wish. However, the level of physical activity involved and the risk for exposure to environmental toxins and industrial hazards should be considered. Maternal safety. Work should not lead to undue fatigue. Frequent rest periods with the feet elevated are essential. Women with jobs that require constant standing or sitting should change positions often or walk briefly to stimulate circulation and reduce fatigue. Tasks that require balance may be hazardous as the center of gravity shifts. Heavy lifting should be avoided. Working women have many home responsibilities. The fatigue and stress of both the home and employment workloads may be difficult during pregnancy. If possible, the expectant mother should adapt her home and employment workloads during pregnancy to reduce fatigue and stress. Exposure to teratogens. Intrauterine exposure to toxic substances is of particular concern during the first trimester, the period of organogenesis. Advise women to investigate their own occupational hazards. For example, nurses and hospital personnel may be exposed to chemotherapy drugs, radiation, anesthetic gases, and infectious diseases such as cytomegalovirus infection. Hair and nail salon workers may be exposed to hairspray and nail products. Laundry and dry cleaning workers may be exposed to phytotoxic compounds, and farm workers may be exposed to pesticides. In addition, some women are exposed to passive smoking in the workplace, which is harmful to both mother and fetus. Travel. Car travel is safe during normal pregnancies. Generally, no more than 6 hours of car travel is recommended a day during pregnancy. Suggest the woman stop to walk every 2 hours to increase venous return from the legs and consider compression stockings. Hydration is also important. Instruct the woman to fasten the seatbelt snugly with the lap belt under her abdomen and across her thighs and the shoulder belt in a diagonal position across her chest and above the bulge of the uterus. This position is uncomfortable for some women, and it causes concern about internal injuries if a collision occurs. However, it is safer to wear the belt than to leave it off and risk ejection from the vehicle during an accident. Travel by plane is generally safe for up to 36 weeks in the absence of complications of pregnancy. Support stockings, periodic movement of the legs and ambulation, avoidance of restrictive clothing, and adequate hydration may help avoid venous thrombosis. The seat belt should be worn at all times because air turbulence is unpredictable. The belt should be buckled below the abdomen. Advise the woman to walk at least every hour to maintain adequate peripheral circulation and avoid thromboembolism. The woman should not travel to remote locations where medical care is unavailable. Suggest she take a copy of her medical records if traveling a long distance. Immunizations. In general, immunizations with live virus vaccines, such as measles, mumps, rubella, and varicella, are contraindicated during pregnancy because they have teratogenic effects on the fetus. Inactivated vaccines are safe and can be used in women who have a risk for developing diseases such as tetanus and influenza. Inactivated influenza vaccine is especially important for women who are pregnant during flu season because it can have serious complications from the disease. It can be given at any point in pregnancy. The CDC recommends administration of the Tdap vaccine between 27 and 36 weeks of each pregnancy. Teaching necessary lifestyle changes. Many expectant parents are willing to make changes in lifestyle to avoid adversely affecting the fetus. Prescription and over-the-counter drugs. Advise pregnant women to consult with their healthcare providers before taking any drugs. This applies to OTC drugs as well as prescription drugs. Some non-steroidal anti-inflammatory drugs, such as aspirin, should be avoided because they may increase bleeding. When prescription drugs are necessary, the healthcare provider weighs the risks against the benefits to decide if a drug can be used safely or if changes are necessary. Drugs taken during the first trimester are of particular concern because of the risk of developing fetal organs. Complementary and alternative therapies. Some complementary and alternative therapies are very safe and helpful during pregnancies. It is estimated that over 1/3 of pregnant women in the United States use some type of alternative therapies during pregnancy, and many of these are seeking treatment for back pain. Many have not been studied adequately. Ask about any complementary or alternative therapies used and advise a woman to discuss them with her healthcare provider. Tobacco. An important aspect of prenatal care is assessment of an intervention for smoking. Approximately 10% of women smoked during the 3 months before pregnancy, and 8.4% of women in the United States smoke at some time during their pregnancy. A Healthy People 2020 objective is that the number of women who stop smoking during the first trimester and do not restart for the entire pregnancy increase to 30% from a baseline of 11.3%. Identify women who smoke. and explain the effects of smoking during pregnancy. Every nurse should screen for tobacco use and refer women to smoking cessation programs as needed. Make every effort to motivate expectant mothers to stop smoking and to avoid contact with others who smoke. Secondhand smoke during pregnancy increases the risk for miscarriage, preterm birth, low birth weight, sudden infant death syndrome, and other complications. The 5A approach to smoking cessation is often effective. 1. Ask the woman at each visit if she smokes, if the amount of smoking has changed, and if she would like to quit. Pregnancy is a time when women are motivated to make changes to benefit their health and the health of the fetus. 2. Advise the woman about the importance of not smoking. 3. Assess the woman's willingness to try to stop smoking. Discuss motivational information if the woman is not willing to quit at this time. Refer the woman to a smoking cessation program if she is willing to try and stop smoking. 4. Assist the woman in making a plan to stop smoking and provide practical counseling on how to solve the problems she may encounter. For example, avoiding others who smoke and being aware of activities she associates with smoking may be helpful. Advise her that total abstinence is essential to success. 5. Arrange follow-up visits or phone calls to discuss the woman's progress and any problems she may have experienced and to offer encouragement. Telephone support may be beneficial in preventing smoking relapse in women who have stopped smoking. Include the woman's partner in discussions of smoking cessation and the effects of smoking on the fetus. The partner's support is especially important in helping the pregnant woman quit smoking. The partner who smokes may be interested in joining a cessation program too. Approximately 50 to 60% of women who stop smoking during pregnancy begin smoking again within 1 year after they give birth. Explain the effects of smoking on infants and provide continued support for smoking cessation during the postpartum period. Although non-pharmacologic methods of smoking cessation are best, nicotine replacement therapy may be used if other methods are unsuccessful. Use of nicotine replacement therapy during pregnancy should occur only under the close supervision of the healthcare provider. Alcohol. Alcohol is a known teratogen, and maternal alcohol use is a leading cause of intellectual disability in the United States. Alcohol may produce a characteristic cluster of developmental anomalies known as fetal alcohol spectrum disorders. Conclusive data about fetal effects of social or moderate drinking are not available, but no amount of alcohol consumed during pregnancy is known to be safe. Therefore, the best advice for women who are pregnant or who plan to become pregnant is to abstain from all alcohol. Illicit drugs. Use of so-called street or recreational drugs such as cocaine, heroin, and methamphetamines is harmful to the fetus. Advise the pregnant woman to seek help to discontinue all illicit drug use. Teaching about signs of possible complications. Instruct the pregnant woman and her family about signs and symptoms that should be reported immediately because they indicate a serious danger. The woman should be instructed to call her healthcare provider or go to the hospital immediately if she thinks she is experiencing complications. Although making the expectant mother aware of signs of complications during pregnancy is crucial, the nurse should take care not to overly worry her. Avoid the term danger signs when talking to the woman and her family because it may be frightening. It is less alarming to say, the signs I am about to explain to you are unusual. But if you notice them, notify your healthcare provider at once because they require immediate attention. Providing resources. Provide the woman with sources for more information. These may include internet websites such as marchadimes.com for information about pregnancy in infants, the Association of Women's Health, Obstetric, and Neonatal Nurses, AHWAN, American College of Nurse Midwives, ACNM, and ACOG provide information websites for all women's health topics, including pregnancy, at blah 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 website addresses. A free service providing information about pregnancy and infants through 1 year is available by text to mobile phones. The service can be accessed by going to the website textforbaby.org. The service is supported by both private and governmental agencies and provides 3 text messages weekly with health tips appropriate to the week of pregnancy or age of the infant. Evaluation. Interventions can be considered to effectively meet the established outcomes if the mother and her family 1. Discuss and practice self-care measures to promote safety and health of the mother and fetus. 2. Explain methods to help relieve common discomforts of pregnancy. And 3. Identify a plan early in pregnancy to modify habits or behaviors that could adversely affect health. If interventions are ineffective, the nurse collaborates with the family to define new plans and work out additional interventions. Application of the nursing process. Psychosocial concerns. Assessment. The purpose of a psychosocial assessment is to monitor the adaptation of the family to pregnancy, which may require a major transition in role function in relationships. For some families, pregnancy offers a potential for growth. For others, an alteration in family processes requires guidance and information. Specific needs can be discovered during a thorough psychosocial assessment. Table 7.4 identifies areas for assessment, provides sample questions, and indicates nursing implications. Identification of patient problems. Most families strive to maintain the health of the expectant mother and fetus and to complete developmental tasks that help the couple to take on the parent role. Perhaps the most encompassing patient issue is the opportunity for improved family coping because of the desire to meet added family needs and assume parenting roles. Planning. Expected outcomes. Expected outcomes include the expectant parents will verbalize emotional responses that are appropriate to each trimester. The family will describe methods to help the expectant parents complete the developmental process of pregnancy. The family will identify cultural factors that may produce conflicts and collaborate to reduce those conflicts. Interventions. Providing information. Provide the prospective parents with information and anticipatory guidance to prepare them for the progressive changes that occur during pregnancy, and reassure them that their feelings and behaviors are normal. Guidance also gives them an opportunity to ask questions and explore their feelings. Common subjects include the following: the emotional changes that occur during pregnancy, the developmental tasks of the mother, role transition, the developmental process of the prospective father. Adapting nursing care to pregnancy progress. Adapt nursing care to the changes that occur in each trimester of pregnancy. During the first trimester, focus on the woman's acceptance of the pregnancy. Tailor teaching to her feelings, physical and psychological, as this is a period of self-focus. The second trimester is a time to concentrate more on the fetus and how the woman and her family will adapt to the changes resulting from the birth. Ask about her fantasies about the baby and her relationships with significant others. The focus is on the woman's discomfort and readiness to give birth during the third trimester. Observe for signs the mother is having difficulty with any of the tasks or steps throughout pregnancy. Discussing resources. Initiate a discussion of the adequacy of the financial situation and support systems, and help couples without financial resources or insurance coverage find a convenient location to obtain prenatal care. This is particularly important for the new poor, who have little knowledge about how to gain access to government-sponsored care. Emotional resources include those that help the new family adjust to the demands of pregnancy and parenting. Discuss the responses and participation of the grandparents. Although emotional responses vary, the family unit is strengthened and the attachment of the grandparents to the child is enhanced when grandparents actively participate in the pregnancy. If family members who traditionally offer help in times of stress are unavailable, refer the prospective parents to community resources such as support groups and childbirth education, sibling breastfeeding, and new parenting classes. Helping the family prepare for birth. During the last trimester, discuss lifestyle changes that will occur when the infant is born. Unanticipated changes that accompany this dramatic life event may add stress and disrupt family processes. Help the prospective parents make practical plans for the infant, such as obtaining clothing and needed equipment and choosing the method of feeding. Assist the parents in planning sibling preparation. Older siblings should be prepared several weeks or even months before the birth. They often benefit from participating in planning for the baby. Younger children have a poor concept of time and can be prepared shortly before the birth. Suggest the expectant parents consider how they will divide household chores, parenting tasks, and childcare, especially if the mother will return to work after childbirth. If these issues are not resolved, the couple can experience frustration and anger when one parent, usually the mother, assumes total care of the infant and attempts to complete all household tasks. Exhaustion and frustration can overwhelm the joys of parenting when one parent must provide all care. Modeling communication technique. When disagreements are evident, discuss and model therapeutic communication techniques that include all significant family members. Techniques to clarify, summarize, and reflect feelings can diffuse negative feelings that might result in family disruption. Identifying conflicting cultural factors. Explore possible areas of conflict related to cultural beliefs and health practices that affect pregnancy. Expectant mothers are reassured when nurses support beneficial health beliefs before confronting them with concerns about healthcare practices. For example, the foods you are choosing are very good for you and the baby. I am worried, though, because you missed your last appointment. If a conflict occurs because of differences in time orientation, acknowledge the problem, convey understanding of the differences, and emphasize the importance of calling when appointments cannot be kept. Many families do not realize that when they miss an appointment, another family misses the opportunity for health care. Evaluation. When the family verbalizes concerns and emotions at each visit, the initial goal is met. Continued interest and involvement of the partner and significant family members are evidence that the family has completed the developmental tasks of pregnancy. Participation with healthcare workers to find a compromise if differing cultural beliefs cause conflict confirms that the family will identify and initiate measures to reduce conflicts. Perinatal education classes. The goals of perinatal education are to help parents become knowledgeable consumers, take an active role in maintaining health during pregnancy and birth, and learn coping techniques for pregnancy, childbirth, and parenting. Meeting these goals helps reduce parents' fear of the unknown and increases their abilities to make informed decisions regarding childbirth and parenting with confidence and satisfaction. Although much perinatal education is accomplished during the prenatal visits, many classes are available and valuable. Perinatal education classes are strongly recommended by the AAP and the ACOG because they can have a beneficial effect on patients' experience. A Healthy People 2020 goal is to increase the proportion of women who attend a series of prepared childbirth classes. Expectant families have many choices for prenatal education classes. Their decisions are based on the classes available in the area, costs, and types of information they need. Small classes of a few women and their partners are ideal, but may be too expensive or unavailable. The teacher is usually an RN who has experience in maternity nursing and is certified by a nationally known organization such as Lamaze International or the International Childbirth Education Association, ICEA. Although most people think of perinatal education primarily as preparation for the birth experience, classes are available for all areas of pregnancy, childbirth, and parenting. Nurses help the woman and her partner find classes suited to their educational needs, provide a list and description of classes in the community, and suggest they talk with others who have taken various classes. The couple may wish to interview teachers to learn about their preparation and philosophies. Some couples want classes that consider avoidance of medication a primary goal of childbirth. Many prefer those that consider a variety of tools, including medication, for coping with pain. Preconception classes. Classes for couples who are thinking about having a baby are designed to help them have a healthy pregnancy from the beginning. Information about nutrition before conception, healthy lifestyle, signs of pregnancy, and choosing a caregiver is presented. The effects of pregnancy and childbirth on a woman's relationships and career are discussed. Preconception classes emphasize early and regular prenatal care beginning before pregnancy and ways to reduce risk factors for poor pregnancy outcome. Education in first trimester. First trimester classes cover information on adapting to pregnancy and understanding what to expect in the months ahead, box 7.2. Emphasis is placed on how to have a healthy pregnancy by obtaining prenatal care and avoiding hazards to the fetus. One important task for expecting women during early pregnancy is to choose the provider and setting that is most appropriate. See Chapter 1. Some women may wish to prepare a birth plan, box 7.3. Education in second trimester. Second trimester classes focus on changes occurring during middle pregnancy and what to expect during the third trimester. Teachers discuss childbirth choices and information to help students become more knowledgeable consumers. With a centering pregnancy model of care, much of the perinatal education is incorporated into the regular prenatal visit. Exercise classes help women keep fit and healthy during pregnancy. Written consent from the primary caregiver may be required to ensure that the woman can participate safely. The instructor should understand special needs of pregnancy and teach low-impact exercises preceded by warm-up routines. Women should avoid excessive heart rate elevation to prevent diversion of blood away from the uterus. The woman with a high-risk pregnancy may have activity restrictions and may be unable to attend regular perinatal classes. If possible, help her arrange for individual instruction. Online courses, CDs, written materials, and phone or email contact with an instructor are ways she can learn and practice techniques without attending classes. Education in third trimester. During the third trimester, women may enroll in prenatal classes to cope with vulnerabilities and fears regarding the upcoming birth. In childbirth preparation classes during the third trimester, women and their support persons learned self-help measures, what to expect during labor and birth, figure 7.6, and how to prepare for the big day, boxes 7.4 and 7.5. Although once referred to as natural childbirth classes, they are now called prepared childbirth classes to denote the woman's preparation for all aspects of childbirth. Couples learn coping methods to help them approach childbirth in a positive manner. Teachers do not promise prevention of all pain and labor. However, the increased confidence in the techniques learned in prepared childbirth classes may help increase tolerance of pain during labor and increase maternal satisfaction with their birth experience. Class series range from a one-day class to 3 to 12 meetings, depending on the content included. Supervised practice of relaxation, breathing techniques, and coping strategies in labor rehearsals may be part of every class. Figure 7.7. Most classes cover information about both pharmacologic and non-pharmacologic methods of coping with labor pain. Although many women plan to have epidural anesthesia during childbirth, non-pharmacologic pain relief measures may be very helpful until the woman can obtain pharmacologic pain relief or in case the anesthesia does not provide complete relief. By learning what to expect during labor and birth, women and their support persons are able to rehearse the experience in their minds in preparation for the actual event. They practice coping techniques during simulated contractions. Realistic, valid class information and discussion of possible variations are essential so couples are adequately prepared. Prepared childbirth classes based in birth facilities include detailed information on what to expect in that particular setting, but may not cover unavailable options. A tour of the maternity areas may be offered as part of the class or as a separate class. Coping techniques. Relaxation. Tension and anxiety during labor cause tightness of abdominal muscles, impeding contractions, and increasing pain by stimulation of nerve endings that heighten awareness of pain. Prolonged muscle tension causes fatigue and increased pain perception. When anxiety and tension are high, uterine contractions are less effective and the length of labor increases. The ability to relax during labor is an important component of coping effectively with childbirth. Relaxation conserves energy, decreases oxygen use, and enhances other pain relief techniques. Most childbirth preparation classes teach women exercises to help them recognize and release tension. The labor partner assists the woman by identifying symptoms of tension and providing feedback to help her relax. For example, she may tighten her shoulders, frown, or jiggle her foot when stressed. Her partner helps her focus on areas she finds difficult to relax. Positive feedback from the partner and teacher encourages increased relaxation. Relaxation exercises should be practiced frequently to be useful during labor. Couples begin practice sessions in a quiet, comfortable setting. Later, they practice in other places to simulate the noise and unfamiliar setting of the hospital. Relaxation exercises may be combined with other techniques such as imagery and massage. Breathing. Historically, specific breathing techniques were taught in childbirth preparations classes. Today, breathing is taught in conjunction with relaxation techniques. Many classes teach a variety of techniques to allow the woman to pick and choose those that work best for her. The cleansing breath, a deep inhalation followed by complete exhalation, is used at the beginning and end of each contraction. This bookmarks the contraction and oxygenates the mother and fetus. With slow abdominal breathing, the patient is told to relax in a comfortable position. Breathe in through the nose until she cannot comfortably take in any more air. Then breathe out through the mouth, forcing out as much air as she can. Breathing techniques maintain oxygenation and provide a distraction for the mother. Breathing techniques include slow-paced, modified paced, and pant blow. With slow-paced breathing, the woman is told to breathe at about half of her normal rate. In 2, 3, 4, out 2, 3, 4. Modified paced breathing is slightly faster than normal, but no more than twice the normal rate. In 2, out 2. Pant blow is also at about twice the normal respiratory rate. With this technique, the woman is taught to take short, shallow breaths in and out with an occasional long exhale, like a sigh. The woman may be taught to say a quiet he with each of the pants and ho with the exhale or blow. The ratio of pants to blows can be varied to provide additional distraction. For example, pant 2, 3, 4, blow. Pant 2, 3, blow. Conditioning. Many techniques for prepared childbirth are based partially on theories of conditioned response, in which certain responses to stimuli become automatic through frequent association. Women learn to associate uterine contractions with relaxation by practicing relaxation techniques with mental images of contractions. Because effective conditioning requires a great deal of practice, women are encouraged to practice their techniques daily. For some women, the intensity of real uterine contractions is surprisingly different from their experiences during practice sessions. They may have difficulty with relaxation as a result, and may need to use other methods along with conditioning. Labor partner. Almost all types of childbirth preparation encourage the participation of someone who remains with the woman throughout labor. This person may be called a labor partner, support person, coach, or labor companion. The presence of a labor partner may help the woman cope more effectively decrease her distress during labor, and result in greater satisfaction with the childbirth experience. The support person shares the experience and helps the woman remain focused and calm during labor. The person who takes on this role may be the baby's father, a relative, a friend, and/or a doula. The labor partner generally attends classes with the mother to learn about labor, birth, and techniques to assist during labor. By practicing together, the woman and her partner learn to work smoothly as a team during labor. Classes may increase confidence for support persons who learn specific techniques to use during labor. When the labor partner is the father, communication and a sense of closeness between the expected parents may be enhanced. Many women hire a doula to assist with labor support. The doula may attend or teach the childbirth class. Encourage couples to think about the support person's labor role before labor begins, and then encourage the partner in whatever role is chosen. Labor partners should not feel responsible for more than is included in the role. Teachers should discuss the duties of the labor nurse and encourage labor partners to seek assistance when they are uncertain. The labor nurse may have helpful suggestions and adaptations of techniques. Class discussion of complications should include the role of the support person in these situations. Methods of childbirth education. Although all methods of prepared childbirth education use some combination of pain management techniques, each method has unique aspects. Many classes have a holistic approach, providing a variety of techniques from which couples can choose those that work best for them. The nurse should give the family a list and description of classes in their community and the philosophies of each class. Dick Reed Childbirth Education. Grantley Dick Reed was an English physician who was one of the first to use education and relaxation techniques to help women through childbirth. According to Dick Reed, fear of childbirth results in tension and pain. To prevent the fear, tension, pain cycle, he developed a method of slow abdominal breathing in early labor and rapid chest breathing in advanced labor. His methods were the first to be called natural childbirth. Bradley Childbirth Education. The Bradley method was the first to include the father as a support person for a husband-coached childbirth. Abdominal breathing to increase relaxation and breath control are taught in these classes. The Bradley method also emphasizes avoidance of medications and other interventions. In addition, classes include general information included in most other childbirth preparation classes. Lamaze Childbirth Education. The Lamaze method is often called psychoprophylaxis because it uses the mind to prevent pain. It involves concentration and conditioning to help the woman respond to contractions with relaxation and various techniques to decrease pain. The Lamaze method is the most popular method used today. A variety of techniques are taught, and women should feel free to choose among them. Table 7.5. Women should not be taught that there is only one right way of responding to labor. Breastfeeding classes. Prenatal breastfeeding education is important because of the short time available after birth to help breastfeeding mothers in the birth facility. Classes help increase a woman's confidence in her ability to breastfeed successfully and provide her with resources if she encounters difficulties. Teachers are often certified lactation consultants who have special education and advanced knowledge about breastfeeding. Breastfeeding classes include information about the various aspects of lactation and help support persons attending learn methods of providing assistance during breastfeeding, box 7.6. Resources for additional help are provided in case the woman encounters difficulties. Some teachers hold additional sessions after the birth to provide ongoing counseling at a time when mothers may experience unexpected problems. These sessions allow discussion of problems as they occur. Classes for partners. Classes for partners often focus on the male perspective of pregnancy, birth, and parenting. They provide an opportunity for men to meet other expectant partners and ask questions they might not ask in classes that include expectant mothers. Some involve practicing infant care techniques with dolls. Classes are often taught by nurses who are experienced partners, or new partners are invited to come and share their experiences. Classes for siblings. Sibling classes are usually for children aged 3 to 12 years. The classes teach them about newborn characteristics and help decrease anxiety about the approaching birth. Figure 7.8. Many young children have never seen a newborn and are expecting a child near their own age who can be a playmate. A visit with a newborn infant allows them to see newborns at close range and learn to be safe helpers. Videos and stories promote discussion about normal feelings of jealousy and anger. Emphasis is placed on the important role of big brothers and sisters and that a baby could not replace them in their parents' affection. A separate parent discussion may provide suggestions for further preparation and ways to cope with the transition after birth. Concerns about sibling rivalry and meeting the needs of more than one child are common topics. Special sibling classes may be held for children who will be present at the birth. These help prepare the child for the sights and sounds of birth. The child support person also attends the class. Parenting and infant care classes. Content for parenting classes typically includes information parents need during the early weeks after the birth, Box 7.7. Baby equipment such as infant car seats is often displayed. Practice with dolls may be included. Classes may continue after the birth of the infant. Postpartum classes. Although the postpartum period is discussed briefly in prepared childbirth classes, in some areas the mother also can attend classes after birth. Content frequently focuses on exercise and nutrition, but may also include the physiologic and psychological changes of the postpartum period. Role transition and sexuality. Signs of postpartum depression may be discussed, with emphasis on when the woman should seek help. Some classes are informal support groups led by a knowledgeable professional.